Rameshwar Garu, now we are live, so we can start.
Yeah, thank you, Savan. Uh, Dr. Arun, sir, with your permission, shall I start?
Please, please.
Yeah, thank you, sir.
Right, sir.
Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request everyone to please do comment your queries in the comment box so that at the end of the webinar, we'll have a short Q&A session. So now let me welcome our today's most respected and very humble person, Dr. Arun M. Boruah, sir, who is a consultant at Apollo Fertility, Guwahati, Assam. And he is a chairperson at any ISAR, any IAGE, and also he is a president of the Berg Ops and Gynec Society, and also he is a senior vice president, IMA Assam State Branch, and vice president, East SOPSI, and active Rotarian for more than 5 years. So with this, we welcome you for today's webinar, sir, and we are very honored to have you for today's webinar. And today's presentation is streamed through the Shield Connect, which is a digital platform of Shield. I request everyone to please do. If you miss any part of this program, it will be available in the Shield Connect. And as we know that the PCOS, these 4 letters can be life-changing. No, we aren't kidding. We mean it is every way. But before we jumping into the conclusions about the hormonal disorder, it is important to do fact check. So do you know why? Because there are million myths around PCOS. So now, without wasting much time, let me turn over the time to Dr. Arun, sir, to talk on myths and facts of PCOS. Over to you, sir.
Thank you, Dr. Sameshwar, and the entire SEAL family for making me a part of today's evening. I'm sure whatever the 4 words you have spoken has been so right that this 4-letter PCOS is really a game changer for any woman or any girl overall. So today we will try to get something in between because this topic has been discussed in multiple forums in multiple ways, right from the complexity to the simplicity, and we are trying to look at how can we really come out of this particular problem. But I tell you, being an Indian, it is really impossible because we carry a different ethnicity and our PCOS is totally different from the Western PCOS that we all try to copy paste in our practice. As you rightly said, there are a lot of myths that we need to really bring it, and what is the facts needs to be focused to the public and also to our patients in general. So that's our small endeavor today evening, that let's first get into with our own colleagues so that they in turn can disperse and percolate the knowledge to their clients so that we go ahead in a right direction to educate the society and create a society which will be of no PCOS. That's what we all aim for. This is a very complex problem, and every one of us will agree that it has a huge genetic component coming into play. And we also have to agree, whenever there is a genetic component, there is equally an environmental factor, and that's where we can always modify the existence of the genetics into the environment. And we have to really commit ourselves to bring this environment more pliable, more affordable, and more accommodative to the patient's concern, so that they bring in and they indulge so easily so that their genetic profile does not get manifested. Otherwise, what we can see is the dominance of diabetes, hyperlipidemia, endometrial hyperplasia, or even cancer, and so on and so forth, even at a very early age in life, because we have this condition called PCOS. Just to start with a small introduction, it's not merely a reproductive disorder. And why do you think this to be a reproductive disorder? Because it manifests really early in puberty and gets prominence in the reproductive years. And that's why most of us think that this is a reproductive disorder. But remember, this carries on to the later life, as I rightly said. And when the reproductive life comes to an almost the fag end, that's where the metabolic problems really supervene. And we will really feel a hell lot of troubleshooting complications if we do not really address this issue right from the time it's being detected. So, hyperandrogenism and infertility remain the two key components of the PCOS, and when these two are stamped into a young girl or I say young woman, I think that's the most distressing time for that particular age of that particular thing. So we need to look at it if we can really do something, and that's where is our endeavor. The precise diagnosis has always eluded us. There is no clear-cut definition and no specific diagnostic criteria because this is considered as a syndrome and we do not see the whole syndrome in totality because whatever we know is the tip of the iceberg only. Why we should know? There's a huge lot of disease complex associated with it because PCOS is associated with infertility, dysfunctional bleeding, obesity, and what not. The later part of life, even dyslipidemia, hypertension, cardiovascular disease, and so on and so forth. And the highest problem arises because it is a familial condition. We know it was described way back in the Hippocrates era and brought into the medical era by the Stein and Leventhal. When we were students, we knew it as Stein and Leventhal syndrome. From there on, the research has really brought this to the stage where we are today. And today we know that this is a condition which is mainly governed, especially in the Indian scenario, by a condition called insulin resistance, because 70 to 80% of the Indian PCOS are governed by insulin resistance. But we'll all be surprised that this insulin resistance has never been included in a diagnostic criteria because the Western group of this particular disease doesn't have insulin resistance. And that is the key difference why we delay in diagnosis, because we always look at the clinical profile of the West, look at the diagnostic modalities of the West, and even if we see the patient in front of our own eyes, we fail to diagnose insulin resistance, and that's why the diagnosis of the PCOS gets delayed further. If we look into the epidemic, as I said, it's a huge impact on the society. Prevalence is to the tune of almost 40%. If we look into the individuality, it is almost 1 in every 5. And 117 million patients, and I can promise every day there are more people, more girls, more women are being diagnosed, provided we widen our vision of diagnosis and the clinicians use the modality of diagnosis to the best of their knowledge. I'm sure there'll be no less than 150 million at least in our country. The complications, especially in our department, carries from infertility to obstetrical complications like diabetes, hypertension, growth restriction. There could be even cardiovascular complications, metabolic complications like metabolic syndrome or what you knew as syndrome X. There could be an oncologic complications like endometrial cancer. But above all, the psychological complications which could be at any time right from the young age, right from the even peri-puberty level to the postmenopausal or even any time during the life period. That is the most distressing symptom because we never read psychological complications so easily. As you said, there is no clear-cut universally accepted definition for PCOS, and I'm sure we create our own definition and try to fit in a patient in a clinical scenario, and that's what we are supposed to do today. On a broader perspective, we like to diagnose this condition based on a clinical presentation, which is oligoamenorrhea. We have laboratory diagnosis, and sometimes we bring in sonography because the ovarian morphology is totally deranged in this particular condition. But overall, the clinical heterogeneity should be a huge suspicion, and we must know the different types of PCOS. It is not always mandatory that insulin resistance has to be there, because there at the other extreme of lean PCOS also exists even in our own country. The sonological classification has been brought into, especially which is typical necklace presentation, and the SRA in 2003 has given us different criteria, but the SRA in 2018 has reclassified it, and today what we follow is SRA 2018 classification, where a clinical history, the clinical scenario is given always a prima facie importance, and the hyperandrogenism, which seems to be more common in the Western, is also present in the Indian type of PCO. So the insulin resistance, hyperandrogenism, and the menstrual irregularity, along with its sequelae like anovulation, infertility, and others, really dominate the whole scenario. Let's look at what are the myths. All women with PCOS have ovarian cyst. The precise word should have been microcyst, because we do not get cysts in the polycystic ovarian syndrome. It is typically microcyst. So that's why the word cyst, when the patients Google, they feel that their ovary is studded with multiple cysts, that as is being reported by our sonological colleagues or even by ourselves. So the fact is, we have to make them understand that there are no real cysts in the ovary, which is a misnomer, and the follicles which harbor their eggs are present in the ovary, and many resemble like strand of pearls, which is known as necklace appearance on ultrasound, is being described as multicystic or the queens of necklace appearance. So these particular myths which are prevailing in the society needs to be clarified by every clinician before we can root out these myths, because they do a lot of psychological damage to the particular girl or the woman concerned, and it is our prerogative to make them clear whatever we know, because that's not the real one. Let's move to myth number 2. We'll have around 10 myths that we'll be talking about today. Women diagnosed with PCOS cannot have children. That means infertility is rampant in PCOS. To a certain extent, this is relatively true. But if we look into the real infertility, it's hardly around 15 to 20% where the PCOS contributes to infertility by anovulation. So, what is the truth? PCOS is a common cause of fertility problem for women, but does not mean carrying a pregnancy to term is impossible. Many women with PCOS can conceive on their own or with the help of fertility treatments. Lifestyle changes and a healthier diet can also improve the chances of conceiving. So practically, we do not offer you any specific treatment. Simple lifestyle can lead you to success in almost 40% of the PCOS patients. So this myth must be cleared to all our patients, especially it is so for those who have insulin resistance. But if you look into the lean PCOS, there also, if the particular inner fat mass can be reduced by lowering your body mass by at least around 2 to 2.5 to even 3 kgs, those patients get enhanced results to the stimulation protocol that is required specific to lean PCOS. Myth number 3, irregular periods. An irregular menstrual cycle means you have PCOS. Yes, people have all the right to take it as a myth, but it is again the prerogative of every clinician to make them clear that whenever you have an irregular period, it is not PCOS. You have to maintain a menstrual diary, and that menstrual diary needs to be produced to the clinician concerned before concluding that your irregularity is really a pathologic one, and that's what the fact is. PCOS is one cause of an irregular menstrual cycle, but there are so many other reasons. Typical cycle range between 21 to 35 days. What I would like to say, I can go up to 37 days. The other factors such as stress, thyroid disorders, endocrine conditions, fibroids, of course not directly but indirectly because it is related to hyperprolactinemia, and extreme dieting can all lead to irregular cycles. And in today's scenario, if you ask me what is the number one cause of irregular cycle, it is stress, especially in the younger women who are more career oriented, and that's why all irregular cycles should not be stamped with PCOS, even if it is being documented by morphological appearance in a sonography. Moving on, what is myth number 4? The woman with PCOS cannot lose weight. I fully agree. There have been little difficulty because the insulin resistance component of the PCOS really makes it little difficult. But it is not impossible. What requires is proper guidance, proper motivation, and what is truth is many women with PCOS have lowered sensitivity to insulin, a hormone that regulates sugar in the blood, and this is known as insulin resistance, which is a risk factor for type 2 diabetes and may make it difficult to lose weight even if you are following a healthy lifestyle. But be patient. I'm sure if you can pursue your lifestyle changes with dietary profiles, I'm sure at the end of 2 months you are bound to get results, and that's why perseverance in your effort, support from your physician, and constant endeavor and constant discussion, especially when you have a group discussions, will help you to create the mood to carry on even if you do not succeed in a short span of 30 days. But we can assure you, you can lose weight. It is not impossible. It is possible for you provided you stick on and your motivation remains high. A very psychologically depressed condition, your physical appearance, is a very important condition of PCOS, and that is due to the hyperandrogenicity which brings in this particular condition. So the myth number 5 says all women with PCOS experiences unwanted hair growth. What do you mean by unwanted hair growth? We will have a hair growth which is sparse and which is female type in all ladies. But when they develop hair growth of a male dominant type, that's what is called as unwanted hair growth, and that is a manifestation of hyperandrogenism. And we also try to look at the different conditions before labeling that particular condition directly as PCOS. So what is the fact? Hirsutism is the clinical terminology that we all know, is excessive growth of male pattern of hair that may appear in woman's face, back, chest, abdomen or thighs, which is very typical of male hair distribution. So it's usually on an underlying sign of PCOS or another endocrine condition. But it is important to remember not every woman will have this symptom, and other factors such as ethnicity can also increase the likelihood of an woman having excess hair growth. So little amount of workup, especially the lab investigations of hyperandrogenemia, should be looked into, and even dermoid, even some adrenal conditions, or even dihydrotestosterone could also be responsible for this hyperandrogenism or even hirsutism. You need to have an ultrasound to be diagnosed with PCOS. And why it's a myth? Because today it has become a habit to look into the pelvis through the ultrasound probe. And I must say, why not? Because doing an internal examination is really not a comfortable area for all the young women or girls. So when we can peep in by doing an ultrasound, we tend to diagnose or overdiagnose PCOS because we forget today's PCOS probes are very high powered probes. They can detect microcyst as well. So we need to know that we do not need an ultrasound to diagnose PCOS, but in younger women, ultrasounds are not recommended at all, because up to the age of 19 years, the diagnosis of PCOS, which is so common, we think them and we treat them, we label them as an adolescent PCOS because of not defining the PCOS sonological configuration perfectly. And that's why I would like to request every one of you, whenever you get a report of PCOS in an adolescent or a girl which is around 19 years and less, please request your sonologist to specify the power of the probe they're using to look into the pelvis. Because the more enhanced power we have with the latest generation ultrasound machine, we'll be detecting more follicles, smaller size follicle to the size of 3 millimeter, 2 millimeter, 5 millimeter, and the numbers will go up. So a polycystic ovarian diagnosis by sonography should have follicles of more than 23. So the probe definition must also be mentioned along with the diagnosis, so the clinicians can tune up perfectly whether this is a real polycystic ovarian morphology or this is a hyperdiagnosis by the high-powered probe that the sonological colleague or even we are using to look into the pelvis. Moving on to the myth number 7. You are not looking to get pregnant. You do not have to worry about the PCOS. No, PCOS is a spectrum. As I told you, it creates a lot of difficulty in getting you pregnant because an ovulation is a part of the game. PCOS does not affect just a woman's fertility. It can impact her long-term wellness for the rest of her life. It has been linked to type 2 diabetes mellitus. Having diabetes in previous earlier ages will really compound her age with a lot of complications subsequently. And besides this, it can also bring in high blood pressure, poor cholesterol levels, also bring in sleep apnea, depression and anxiety. So whenever you diagnose PCOS, it's not because of the fertility issues you need to address, but you need to address to prevent her from going into the metabolic complications and make her aware of the things to come, because always fertility may not be her primary focus. The next myth: everyone with PCOS is obese or overweight. As I just recently said, insulin resistance or a typical PCOS Indian patient is really an obese one. But there could be atypical. As I said, there could be lean PCOS as well. So the fact is, there is a misconception that you may have to be stereotypical overweight woman. It's image of a bearded fat lady. PCOS is a syndrome. It affects people at many different ways, and therefore the lean PCOS women also exist in the society, and we do get these PCOS patients who comes to us with infertility. For them an ovulation and the stromal thickening is really high. They have a very high LH levels, so they need also to be realized by every clinician before we label them as non-PCOS. Insulin resistance in PCOS causes weight gain. People say, and whereas I would like to bring in the fact that the reality is that experts are not sure why a woman with PCOS are often overweight. We all know insulin has a huge role to play with it, but real factor has yet to be emerged, and we are looking into it, and that's why some women find it so difficult to reduce her weight even they have hyperinsulinemia corrected. Many people say it's because of the insulin resistance, but while weight gain causes insulin resistance doesn't cause weight gain. So we are still in a dark area of why insulin resistance and weight gain are common in PCOS. Myth number 10, every woman with PCOS should go on for the birth control pill. Now, why this has become a myth? These myths have become a reality in the society because we have compelled them to believe. We probably do not speak a few words whenever in a PCOS we prescribe these pills. The reason behind the prescription of pills is to get control of hyperandrogenemia and also in some cases to correct their menstrual irregularity. But it doesn't mean that every PCOS patient will require pills to control the whole scenario. So what is the fact? The fact is the hormonal birth control is a common way for all of us to treat menstrual irregularities of PCOS. But the treatment of PCOS will largely depend on your end, what you desire, whether you are desiring a fertility, whether you are desiring a reduction of your body mass, whether you're looking to improve your physical health in the form of reduction of acne. So those will define not really our own choice. We talked about this diagnosis and still the diagnosis remains elusive. The spectrum is really huge. Some symptomatology really overlaps both the PCOS and non-PCOS patient, even if it is puberty or reproductive years or even postmenopausal years. But this is a very important slide for all of us, those who are viewing in. The phenotypes of PCOS, there are especially 4 different phenotypes and every phenotype has its own significance. Look at the phenotype A. We have hyperandrogenism and hirsutism. We have ovulatory dysfunction and we have also sonological manifestation of polycystic ovarian syndrome. Whereas in a phenotype D, we have only sonological manifestation and menstrual dysfunction. In type C, we do not have ovulatory dysfunction. They have regular periods, but we have hyperandrogenism and polycystic changes in a sonological examination. Whereas in phenotype B, we do not have any sonological changes. We have only irregular cycles and also we have hyperandrogenism and hirsutism. So these different types will need to be treated in a different way because detecting phenotype and configuring them remains a prima facie in the line of treatment of PCOS. We also know that there could be PCOS in the postmenopausal woman and accordingly we need to move ahead. The epidemiological link is so important because there is enhanced risk of type 2 diabetes as we have rightly discussed. Especially in the reproductive age groups, they are bound to manifest with gestational diabetes mellitus and every patient who is treated for PCOS when they become pregnant, this patient must be routinely screened at least 4 times during their pregnancy for GDM detection as early as possible because if we can reduce GDM during that index pregnancy or if you can delay its manifestation, I think we are taking good control of the fetus in situ because we also have to appreciate the fetus will carry informations for the next 3 generations. So our endeavor to create a good milieu in a fetal environment is important. So insulin resistance is present in PCOD cases. That's what we already have discussed. GDM will develop to type 2 diabetes. So whenever these patients become pregnant, as I said, it's our endeavor to monitor them, to look them for the earliest hyperglycemia because all patients in pregnancy have a tendency to develop hyperglycemia anyway because of the insulin resistance of pregnancy itself. So the basic pathophysiology is considerable debate on what exactly constitutes the disease because as I said we do not know that till yet. But the biochemical features present in the vast majority of women with PCOS are: one is insulin resistance, one is chronic low-grade inflammation in PCOS, and that is why it is so difficult to treat. This is a very important slide, and I'm sure those of you who are tuning in should try to understand this, because these 6 steps of insulin resistance, if we understand thoroughly, I think the PCOS will be better understood by all of you. The first is the control of LH levels. We know there's LH levels are tremendously increased in all PCOS patients because this LH is governed mostly by the insulin, and we again know that in insulin resistance there is hyperinsulinemia, so that insulin and LH are interlinked, and that's what the whole pathology starts with. Point number 2, it controls the androgen levels, because the insulin mediates androgen production in the theca cells of the ovary, and that is why the role of inositols can also be incorporated, because they help, and that's why treating these patients can optimize the ovarian milieu and ultimately help in getting ovulatory cycles from an ovulation. Insulin resistance coexists with PCOD, inositol deficiency drives PCOD, and insulin signaling is damaged in PCOD, and lastly it leads to the hormonal and metabolic defect, because insulin dysfunction disrupts LH FSH pathways, and when we have FSH, low FSH, we will not be able to generate sufficient amount of estrogen, and that's why the cycle will remain anovular. Evolution of PCOD, just to sum it up, there has to be a pituitary dysfunction, which in turn goes into the enhanced ovarian androgen production, and ultimately there will be development of insulin resistance, and this cycle needs to be broken somehow, whether this is due to genetic factors or it is due to environmental factors. We need to bring in more of an environmental factors, because we cannot manipulate the genetic factors, and if we can do that, we will succeed in taking the subject in the right direction. The clinical features mostly are gynecological, metabolic, and androgenic that we all have talked about. I'm not going to take them one by one. So myths and facts remain, and we will have to take an extra step out of our clinical room to make people aware. So what is exactly the true picture of this dreaded condition, which is rising enormously, not only as an urban disease, it has reached out to the village and also in every nook and corner of our country. Few lines or few slides about the treatment. Lifestyle remains an important area of environmental care, and that's where we achieve success in almost around 40%. And this is more prerogative because once these patients who are willing to become pregnant conceives with lifestyle changes, they get a better pregnancy support because of the obesity which is being taken care of prior to conception. Weight loss, changes in diet, and physical activity are 3 prime pillars of lifestyle modification. And the weight loss decreases serum insulin, and everyone knows that decreasing your weight by 5% really improves the ovarian milieu and also enhances fertility prospects. This is a little busy slide, and we are trying to know that we always treat the symptoms, we do not look into the cause. But if you're looking into the insulin resistance as a whole, I think we'll be able to take care of 80% of the causes of PCOS overall in our country. A few words about the inositol in PCOS. Every buzz is going around, and we know that inositol has come up in a big way, and the role is mostly to improve the ovarian milieu, and also we have to appreciate the inositol has a role in a peripheral conversion of insulin as well. I'm not going to take this on a regular basis because today we are talking mostly of the myths and facts, but myoinositol in PCOS is going to stay, and it is really giving us a better environmental ovarian environmental care, and that's how the fertility is being restored for all of us. evidence is flowing fast, so we start using myoinositol in PCOS patients because they enhances ovulation as well. So finally, in my conclusion slides, we have to remember that PCOS is a multifaceted condition. Multidisciplinary approach for subfertility and ovulation is required, and the most important disciplines that we need to be friendly are dermatology, endocrinology, even the internal medicine, and also the geriatric group, because they all come into play in the long run. And this is a condition or a spectrum where the treatment or the diagnosis needs to be initiated early, and the support needs to be given till our fag end of our life. A holistic care to increase success rate of fertility treatment needs to be employed. Lifestyle modification like diet, exercise, and behavioral therapy are the principal treatment, and they are more achieving success when you do it in groups, and that's why awareness and a group practice is more important. Low dose gonadotropin can be used as a first line agent when affordability is not a question, and accessibility are also there, because they take good care of ovulatory cycles and bring in success and bring in the correction of the ovarian milieu that I bring in repeatedly in my talk, because until and unless we correct the ovarian milieu, the PCOS is not going to be corrected permanently. IVF and ICSI are indicated when the previous interventions like failed tubal occlusions, or there could be an associated male factor. I can assure you this is a treatable condition, but a little amount of extra effort is required from every one of us, because they need a lot of patient hearing. And today we do not have that particular condition for all of us, because time has remained a very important component, and we try to preserve them for a near and dear ones. Please consider these PCOS patients to be your near and dear ones, and I'm sure your success is bound to be on your cards. Thank you so much for being with me for last 35 to 40 minutes. I'm sure I have been able to give you an overall impression which you already know. And if you still want to know further, I'll be with you for next 10-15 minutes or even longer if you really want me to clarify. Thank you so much, SIL Healthcare and SIL Connect, for giving me this opportunity to connect with every one of you. Thank you once again.
Thank you very much, sir. We are very honored to have you, sir, and it was very great learning and honored to have you, sir. And thank you, sir, for debunking so many myths around the PCOS. And we are surprised to see that there are so many myths for PCOS. So thank you very much, sir, for the excellent presentation. Sir, if you allow me, then we will take the questions.
Please.
Yes. Sir, we have a first question that whether bariatric surgery can benefit the PCOS patients.
Now, as we discussed, lifestyle management is the prima facie in a treatment profile, especially when there is an insulin resistance and obesity coming in. Now, bariatric surgery will definitely help, but this will not be the first line of treatment when I consider to my group of patients. But having said so, if your traditional care is not taking care of reduction of our body mass, then as a last resort, I will definitely prefer to go to even that extent, because taking care of our weight by doing a bariatric surgery, which is really catching up fast in all metro cities or even tier 2 cities, could bring them a lot of success spontaneously. So the final conclusion is, yes, there is a role of bariatric surgery in obese PCOS patients, but not as the first line of therapy. But when all therapies that are being recommended fail to give us results, we can always bring them in to our protocol.
Thank you very much, sir. We have one more question, sir. That is, if one ovary is involved, can we label it as PCOS?
Yes, as I said, sonological diagnosis is not giving us so importance today. What we have to look at the clinical presentation and the clinical manifestation along with the hyperandrogenic lab diagnosis, which is more important. But we have always seen that there is an isolated one-sided ovarian morphology which are detected, and even on this particular thing, when these patients have a clinical manifestation, when they present with biological manifestations, yes, they should be labeled and treated as PCOS patients.
Thank you very much, sir. We have one more question, that is chronic inflammation and PCOS. Is there any relationship?
Yes, there is a strong relationship. We have to understand that fat is considered the largest endocrine organ today. And we all know this adipocytes inflammation is the root cause of inflammatory theory of PCOS. Now, how I look at these patients are, if the patients find it so difficult to reduce their weight, I do an ultra sensitive CRP. If it turns out to be high, I'm sure that inflammatory component of this group of patients to this PCOS is so important, and I start treating them. And if you really use the drugs to get this inflammation down, and I'm sure they will respond well, and that has been my way of practice. And also, we also know that combination of metformin and myoinositol, they also add to certain amount of weight reduction by metformin and inositol combination in the ovarian morphology. They also induce reduction in the inflammatory parameters and bring in success both in lowering the weight and also enhances fertility.
Thank you very much, sir. We have one more question, sir. Whether PCOS can cause primary amenorrhea?
Yes, definitely yes, but the primary amenorrhea could be an initial manifestation. It cannot be a diagnosis, because primary amenorrhea will become a final diagnosis only when your patient will not have an withdrawal to the hormonal therapy. But these PCOS patients usually have an withdrawal bleeding. But whenever we take a primary amenorrhea, as I said earlier in my presentation, during the peri-pubertal period, if the adiposity remains so high, if the LH hormone remains tremendously high, the LH-FSH ratio is altered to the great extent, there will be difficulty in having their menstrual initiation, and those patients in many occasions are labeled as primary amenorrhea, but those are not true primary amenorrhea, because at one point of time they are going to have an bleeding anyway. So primary amenorrhea overall can be one of the manifestations of PCOS patients, but when you come to the final diagnosis, no, because primary amenorrhea and PCOS, they are not the final diagnosis.
Yeah. Thank you very much, sir. I think there are no more questions from the delegates. And I request HR Balaji sir to thank the Dr. Arun sir. Over to Balaji sir.
Good evening, doctors.
Good evening.
Yeah, thanks to each one of you for sparing your time today. And my special thanks to Boruah sir. We are really honored, sir. Because I know Dr. Boruah sir as a dedicated person. If I have to tell a little more about him, his contribution to the real rural and people who are downtrodden, he's doing tremendous work there. And his passion towards the adolescent girls and the women's health, I really salute him. In fact, I was not able to join before the meeting started because I was just traveling. I sincerely thank Boruah sir. He said, no, Shield family definitely is a well-wisher for us. My sincere thanks to everyone, and my sincere thanks to Arun Boruah sir. Thank you very much, sir.
Thank you so much for appreciating. Thank you.
Thank you, sir.
Uh, Thank you very much, sir. Sir, with your permission, shall we close the webinar, sir?
Sure. Thank you
Yeah.
so much once again, Sil Connect. And if we are off the record, I just like to speak one or two words to Balaji sir.